This recording will cover COPD. COPD stands for chronic obstructive pulmonary disease, and it interferes with airflow and gas exchange. These disorders include emphysema and chronic bronchitis. Tissue damage is not reversible. It increases in severity and eventually leads to respiratory failure. Emphysema leads to the loss of lung elasticity and hyperinflation of the lungs, which causes dyspnea, decreased gas exchange, and increased respiratory rate. When you think of emphysema, think of alveoli that aren't working correctly. They're destroyed or damaged, characterized as being large and flabby. They have decreased area for gas exchange. Remember, alveoli are it's the part of the lung where gas exchange occurs. So if they're not functioning correctly, as in with emphysema, it's going to decrease gas exchange. Also, with emphysema, we see air trapping and hyperinflated lungs. The diaphragm is less effective and accessory muscles are used. The patient experiences air hunger, which is a feeling as if they're not getting enough air in and they keep trying to get a better breath. Late stage in emphysema, we see chronic carbon dioxide retention, chronic respiratory acidosis, and low PaO2. Emphysema is associated with smoking. And remember, it's an alveolar problem, not an airway problem. Chronic bronchitis is inflammation of the bronchi and bronchioles caused by exposure to irritants, especially cigarette smoke. The irritant triggers inflammation, vasodilation, mucosal edema, congestion, and bronchospasm. The patient's lungs will produce large amounts of thick mucus, and the bronchial walls will thicken and impair airflows. Both the mucus and the thickened walls impairing airflow block some of the smaller airways and narrow larger ones. The increased mucus causes the patient to be more prone to chronic infections. Mucus plugs and infection narrows the airway, which leads to decreased gas exchange, decreased PaO2, increased PaCO2, and respiratory acidosis. Remember, chronic bronchitis affects the airways, not the alveoli. Chronic bronchitis is an airway problem. Risk factors for COPD include cigarette smoking, a genetic risk factor known as an alpha-1 antitrypsin deficiency, and also asthma appears to be a risk factor for COPD. COPD is seen more frequently in older men. When conducting a patient history, you want to ask about a family history of emphysema, what they did for a living, their occupational history, if they're a smoker. Have they been experiencing any dyspnea, coughing, or sputum? Has anything triggered their respiratory problems? Have they had a change in activity level? Have they experienced orthopnea? Do you remember that term, orthopnea? That would mean the patient has problems breathing when laying flat. They breathe better when sitting up. Also, do they have any unplanned weight loss? The general appearance of a patient with severe COPD is thin with loss of muscle mass in the extremities, and the neck muscles may be enlarged. Commonly, you'll see the patient in a tripod position when they are struggling to breathe, and you'll see that here on the slide. So they'll either have both their hands on their legs or their knees leaning forward, or else they may be leaning forward with their elbows on a bedside table, and that just helps open up the chest to improve breathing. With severe activity intolerance, the patient may neglect grooming and hygiene. So some signs and symptoms that you'll be seeing in your patient with COPD include respiratory changes, accessory muscles, retraction, asymmetric chest expansion. The patient will have increased respiratory rate with acute exacerbations. Fremitus will decrease. Wheezing may be noted. Crackles are not usually present. The patient may have diminished breath sounds, especially with emphysema. Assess the degree of dyspnea. We have a little chart coming up on that, and also the patient may have a barrel chest. With a barrel chest, the ratio between the anterior-posterior diameter of the chest and its lateral diameter is 1:1 rather than the normal 1:1.5. And what it looks like normally when you're straight onto a person, they're wider than if they turn sideways, right? But with barrel chests, they'll appear the same width regardless if you're facing them or if they're sideways. Here's an example of a dyspnea assessment tool. You can have the patient indicate the amount of shortness of breath they're having at any time by marking on the line from either no shortness of breath to shortness of breath as bad as it can be. Cardiac changes included right-sided heart failure, also known as cor pulmonale. And if you see in the name pulmonale, you should think of lungs when you think of pulmonary. So anytime any patient who has a lung disorder is at risk for a heart disorder because it is the heart that pumps blood to the lungs. So if the lungs aren't working well, you can sort of backtrack to what the next problem will be, and it'll be a problem with the heart, the right side of the heart, because the right side of the heart is what pumps into the lungs. Pallor and cyanosis can also be noticed. In terms of psychosocial issues, the patient may be isolated due to dyspnea or embarrassment from coughing. The patient, you want to ask about hobbies or smoking, their economic status, and also if they're experiencing any anxiety or fear due to air hunger. So here we have a picture of the pink puffer, and this is a little diagram that can help you remember emphysema. So go ahead and pause the video and you can review over this illustration to help remember pink puffer emphysema. And now we have the blue bloater. The blue bloater can help you remember chronic bronchitis. So go ahead and pause the video and check over this illustration. Complications of COPD include hypoxemia and tissue anoxia or hypoxia, acidosis, respiratory infections, again because of that excess mucus is a happy breeding ground for infection and bacteria, cardiac failure, especially cor pulmonale, which is right-sided heart failure, and also cardiac dysrhythmias. In terms of labs and diagnostics, we're going to be looking at the patient's ABGs because that gives us our best information about oxygen and carbon dioxide levels in the blood. Sputum samples, a CNS can be done to detect any infection. H&H, if the patient isn't getting enough oxygen, they will produce more red blood cells and the H&H will increase as a means of compensating for the low oxygen levels. Electrolytes and also serum AAT to detect any genetic causes. A chest x-ray may be conducted to rule out other lung diseases and check for infection. With advanced emphysema, the chest x-ray will show hyperinflation and a flattened diaphragm. Pulmonary function tests may also be performed. Pulmonary function tests are also used, and we'll talk more about those in a minute. COPD assessment tests can be done and ask the patient about their symptoms. The patient with COPD has lower oxygen, often lower than 90%. So a lot of times your COPD patients will have specific orders from the physician that may say keep oxygen between 88 and 92% because that is the sweet spot for a COPD patient. So don't be afraid to administer oxygen to your COPD patient, but no, the goal isn't to have the COPD patient at 100% or even 98%, 96%, because they're usually chronically hypoxic. So the goal will be a little lower, 88 to 92%. With these different pulmonary function tests, a lot of times the name will tell you what it is that's being measured. So we see vital capacity, total amount exhaled per minute. So what had been held, what can you get rid of? RV, residual volume. Residual means what's being left over. Amount of air remaining in the lungs at the end of forced full exhalation. Forced expiratory volume, how much air a person can exhale during a forced breath. Total lung capacity, amount of air in the lungs at the end of maximum inhalation. So how much can you hold? What's the most that you can hold in your lungs? Forced expiratory volume in 1 second records the maximum amount of air that can be exhaled in the first second of expiration. And forced vital capacity is the maximum amount of air that can be exhaled as quickly as possible after maximum inspiration.